Welcome back. As I mentioned, we have Dr. Daniel Walters here, who is an interventional cardiologist with Memorial Care, Saddleback Medical Center. Well, welcome. How are you?
Good morning. Thank you so much for having me today.
Oh, you're welcome. Well, we are interested to learn about you since this is your first time here with us. So let's just jump into that. You're an interventional cardiologist. You've been with Memorial Care for just a little bit. Tell me where you're from and why you got into this.
Absolutely, yeah. So I've been with Memorial Care for about 2 months now. I'm an interventional cardiologist by training, and I was on faculty at UC San Diego for 3 years before I came up here. My wife and I are both from Michigan originally, where we did our medical school and our training, and she has family locally in the area in Aliso Viejo, and we visited here 11 years ago, my first time ever in California, and I just told her, why are we not practicing medicine here already?
Yeah.
So we came out when we had the opportunity to continue our training in San Diego, and then moved up here when the opportunity arose just a few months ago.
Oh, that's great. Well, yeah, coming from an area like Michigan, which is great for your schooling, but that when it comes to the weather, I'm sure this is a lot better.
It's beautiful for 3 months of the year.
Well, you can always just go visit during those months, right?
We are visiting next week.
Perfect, perfect. Well, let's talk about what it means to be a cardiologist and an interventional cardiologist. What is the difference?
Sure. So a cardiologist is someone that's completed their basic 3 years of internal medicine training, and then on top of that, another 3 years of general cardiology fellowship. So there's a number of those throughout the country, and that's where you learn the basics of the full litany of cardiac care. Interventional cardiology training is then a specific program beyond that. It's 1 to 2 years. At UC San Diego, where I trained, it's a 2-year program where you essentially focus just on minimally invasive procedures, how to perform them, and how to do things like open blocked heart arteries in patients that have narrowed arteries because of calcium or cholesterol. And in the second year that I did, and that's something is becoming more prevalent, how to also do minimally invasive valve replacements, something which is really a brand new treatment that didn't even exist when I was younger, just a decade ago.
Right, and technology is moving very fast, as I think we certainly are seeing, and what you can attest to. So when you talk about minimally invasive, you just mentioned stenting. So what does that involve?
Yeah, so stenting, the basics of the procedure involve placing an IV into the artery, either of the wrist or the groin. That allows us to then deliver equipment into your heart itself. And using that equipment, we can visualize the arteries, the trajectory they take, areas that look like narrowed components because of calcium or cholesterol that's developed over time. And if need be, because of symptoms such as chest pain or an abnormal stress test, or because of treatment needs for something like a heart attack, we can actually use a balloon to open up those blockages and then place a stent if need be to act as a scaffold to prevent those blockages from hopefully recurring. Okay,
and then the other ones that you mentioned, well, I have them here, is Watchman and TAVR. So those are the actual descriptions of the operation itself?
Those are actually a little bit different than the stenting of the heart arteries. So those are the structural procedures that we do independent of the arteries themselves.
Okay.
TAVR or TAVR is a way to minimally invasively replace the aortic valve. This is something that was an open heart surgery up until the early 2000s when this was first developed, actually in Paris, and eventually brought to the United States. And it's becoming, in many instances, the standard of care for what was initially patients that were deemed too high risk to undergo an open heart surgery, but now often for patients that simply choose not to undergo an open heart surgery and instead prefer a minimally invasive route.
Right.
It's something that we are doing dozens of locally here at Saddleback and through Memorial Care with excellent outcomes, and it's a great way to get a patient who wants to avoid an open heart surgery through a procedure that has significant benefit after the fact.
Well, and then also I think if you look at the differences of recovery, I mean, obviously people will probably be back up on their feet within, what, days?
It's tremendous. We at our institution have a standard of care in place where typically it's 1 night of observation in the hospital.
Wow.
And even that 1 night is often just precautionary. Patients that have their procedure in the morning, in theory, could go home that same day, and that's something we are exploring.
That's crazy. I
mean, it's fantastic.
It is, right? Because, I mean, we don't want to have surgery, but when you have to have surgery, having something minimal like that is definitely ideal. You know, when it comes to heart risk, there are things that we should be doing to either monitor what we're doing prior to this, or once we find out, what are some things?
Yeah, that's an excellent question. So certainly looking at things like diet and exercise, what we call primary prevention is very important. That's the idea of preventing a heart attack, preventing a stroke. There are some cardiac diseases that can't be prevented. Things like calcific buildup of the heart valves can't be prevented over time. Some of that's genetic. Some things necessarily are influenced by where you live, your culture, stiffening of the heart, stiffening of the heart arteries. But overall, routine daily activity, moderate exercise, walking, and then the best evidence that we have is for a Mediterranean diet, where you really focus on healthy whole grains, fruits, vegetables, good sources of protein like fish, and then avoidance of what I say are the aisle foods. So when you're at the grocery store, stay around the perimeter and avoid those processed foods down the aisles.
That's a lot of coverage. That's going to be hard to just go to the exterior ones. Something that you mentioned was the calcium buildup, and you said that was genetic. When do you know that you have that?
Excellent question. So some of this is found incidentally. Patients may get a chest x-ray for something else, and they see calcium on a heart valve. They may get a CAT scan because they were a former smoker in their 20s or 30s, and that CAT scan shows calcium in the heart arteries. So for those incidental findings, a lot of the patients that we end up seeing may need a stress test or further evaluation to determine if it's significant or not.
Okay.
Some patients, though, come in with new chest discomfort or chest pain. That's a very common finding. And then more commonly, even these days, we're seeing what we call atypical symptoms. So people that don't have kind of the clutching left side pressure that dad in the 1960s had, but more breathlessness or easy fatigue with their typical daily activities. Women in particular often come in with episodes of nausea or cold sweats, and that can be a sign that there's something going on as well.
Oh boy, that's definitely interesting. So cold sweats versus hot flashes. we have to make sure we make that distinction. All right, now Memorial Care has a heart risk assessment. What's involved with that?
Yeah, so anytime a patient comes into the emergency department or is in the hospital for any reason, the heart risk assessment's a general approach for us to take and say, what is their presentation for at the hospital stay? Is it cardiac or non-cardiac related? And if there's any question, then the heart risk helps us to determine, do we need to get a cardiologist involved? How soon does that need to happen? Another thing that we do at Saddleback and Memorial Care, any patient that comes in with any cardiac concern immediately in the ER has an EKG performed.
Okay.
And that triggers our 24/7 on-call team care to be prepared if there is an urgent heart attack need to immediately come in and perform a procedure as necessary if there's a blocked artery or something else urgent that needs to be done.
Okay, excellent. Well, is there anything I might have missed?
Well, there's so much to do with cardiac disease and cardiac care. There's a lot of development on the horizon, especially with the minimally invasive structural approach. We discussed valve replacement for the aortic valve. We also now have minimally invasive ways to repair the mitral valve, something that was also previously an open heart surgery as well. And then the Watchman procedure that you mentioned also, that's something that we can potentially use more commonly moving forward to reduce the need for blood thinners in patients that have that because of abnormal heart rhythms. So part of what I've looked to do since I've moved down here into South Orange County Cardiology is expand that care to our patients and to meet all of their needs and to keep that hopefully right here at home in Saddleback and at Memorial Care.
Well, that will certainly be nice for most people to get off blood thinners because there's so much going on in your body when you have blood thinners. I mean, bruising and so many other things. So that'll be quite a nice thing to have.
And I'm blown away by the number of patients I have that say, it's $600 per month, doctor.
Oh,
and I
that's
just
too
say,
bad.
oh my goodness.
Exactly, exactly. Well, good luck with that one. That'll be awesome. Well, thank you so much. It was very nice to meet you.
Absolutely. Thank you so much for having me. It's a pleasure.
And congratulations on getting to SoCal.
Thank you so much. I'm looking forward to staying here for as long as possible.
All right. And if you want more information about risk assessment, you can always get in touch with memorialcare.org/MHVI. We'll be right back.